Let's look at pelvic inflammatory disease. What is pelvic inflammatory disease? It is actually an infection and inflammation of the female upper genital tract, that's the uterus, fallopian tubes, and or ovaries. It's usually due to ascending infection from the lower genital tract. That's infection usually ascend from the vagina or cervix towards the fallopian tubes, ovaries, or even the uterus. What are the causes? Sexually transmitted pathogens. Most common is Neisseria gonorrhea, Chlamydia trachomatis. Other organisms could be mixed or anaerobic, such as Mycoplasma genitalium, anaerobes such as bacteria or Peptostreptococcus, enteric bacteria such as Escherichia coli. What are the risk factors? Multiple sexual partners, unprotected intercourse, previous sexually transmitted infection or pelvic inflammatory disease, recent uterine instrumentation, that's IUD insertion or taking of endometrial biopsy. Let's look at the pathogenesis. Infection spreads from the cervix or vagina upwards, which results into endometritis, that's inflammation of the endometrium, which will further result into salpingitis, which is inflammation of the fallopian tubes, would affect the ovaries subsequently, resulting into ophoritis or parametritis. Ophoritis, which is inflammation of the ovaries, which will further result into pelvic peritonitis or tubal ovarian abscess. What are the clinical features? Lower abdominal or pelvic pain, which is most common, fever, abnormal vaginal discharge, which is usually purulent, deep dyspareunia, which is pain during intercourse, dysuria, which is pain on urination, happens sometimes, irregular menstrual bleeding, cervical motion tenderness, uterine tenderness, adnexal tenderness on pelvic exam, which is chandelier sign. In severe cases, there's nausea, vomiting, and peritonitis. How do you make diagnosis? Clinical diagnosis is most important. There's no single definitive test. You can do supportive tests, positive pregnancy tests to exclude ectopic pregnancy, vagina or cervical swabs, that's nucleic acid amplification tests for Neisseria gonorrhea or Chlamydia trachomatis, ESR/CRP if they are raised, ultrasound to assess for ovarian abscess, thickened fallopian tubes, can do laparoscopy, which is gold standard but not routinely done. What are the complications of PID? Infertility due to tubal scarring, chronic pelvic pain, ectopic pregnancy, tubo-ovarian abscess, Fitzhugh-Curtis syndrome, perihepatitis causing right upper quadrant pain. How do you treat PID? Prompt empiric antibiotics covering Neisseria gonorrhea, Chlamydia trachomatis, and other anaerobes. Outpatient regimen CDC recommended ceftriaxone 500 mg intramuscular, single dose plus doxycycline 100 mg orally twice daily for 14 days. Can either give metronidazole 500 mg orally twice daily for 14 days or not. Can do inpatient regimen in severe cases, IV cefoxitin or cefotitan plus IV doxycycline plus IV clindamycin plus IV gentamicin. Treat sexual partners for sexually transmitted infections. Advise abstinence until therapy is completed. Drain abscess surgically if present or ruptured. How do you prevent PID? Safe sex practices such as the use of condoms, fewer partners, early screening/treatment of sexually transmitted infections, prompt management of lower genital tract infections. Let's briefly look at the signs and symptoms of PID again. Pain in lower abdomen, foul smelling vaginal discharge, fever, painful intercourse, irregular periods, painful urination, etc. Thanks for listening.